Welcomes all the participants for today's National Distance Learning Seminar series. Today's topic is pre-exposure prophylaxis and treatment as prevention, and speaker is Dr. Anwar Parvez Syed. Dr. Anwar is a public health specialist and HIV and TB physician. He is a fellow in HIV from International Training and Education Center for Health. He is presently serving ITEC India as Senior Medical Advisor, where he is working in close coordination with NACO in providing national and regional level technical assistance for strengthening the capacities of COEs in HIV care across the country and assisting HIV treatment program. He is a national level trainer for NACO and has been involved with NACO training since 2011. His major areas of interest include training, capacity building, curriculum development, distance learning, HIV/AIDS and tuberculosis program management, and public health intervention programs. We welcome you, sir, for today's NDLS session. I would request Dr. Anwar to take over the session now.
And a very good afternoon, all of you, and welcome again for this session today. So in this 1 hour, we will be trying to discuss on the pre-exposure prophylaxis and treatment as prevention. Now, there is a specific reason behind why I try to choose this topic and talk about it, as we very well know that these are the topics which are, or these are the interventions which are not directly part of national guidelines as of now. So while going through this session, we need to remember this aspect very carefully, and the reason behind selecting this topic is that there is a lot of evidence which is coming up recently, and also there are lots of discussions which are happening in various national and international fora regarding these strategies. So we as people who treat HIV positives and who are part of one of the biggest treatment programs in the world, so we should be aware of the recent progresses and recent discussions which are happening. So this session is an attempt towards expose or providing an exposure to some of the data which is relevant to these aspects, and just as an introductory thing, so we might not go in details of these two intervention strategies, but I'll try my level best to make these things clear to the audience. So the outline for this session is we will try to talk about the HIV prevention strategies in brief, just a slide or two on this. Then we will be talking on treatment as prevention, and then pre-exposure prophylaxis. As I mentioned before, please remember that these strategies are not part of national AIDS control program, or there are no NACO guidelines of this. So we will be following NACO guidelines as far as implementation in our ART centers is concerned. So please be very clear on that. There should not be any confusion after this session. So this is just a kind of orientation or kind of discussion on these important areas which are very attractive these days and which are discussed at length in any fora where HIV is discussed. To start with, these are HIV prevention strategies. We very well know in our program also there are various HIV prevention strategies which we see, like targeted intervention programs, and which bring about which are actually major focus of HIV prevention program under NACP 4 also. So if we want to divide broadly all these prevention strategies, we can divide it in non-ARV based strategies and ARV based strategies. If we look at non-ARV based strategies, these are very obvious, and we already use these strategies in our national program also, like behavior change communication, like which means essentially bringing people or working on high risk behaviors of some of the populations to change their behavior to low risk or no risk behaviors. Then condom has been a major strategy, or condom usage has been a major strategies in HIV prevention for long time now. There are needle exchange programs or clean injection equipment. In some parts of the world there are medical male circumcision programs, which are wherever it is relevant and wherever it is acceptable. It is now in many countries they use the medical male circumcision as a prevention strategy in their programs. So wherever it is culturally acceptable, people use them. Then STI, we are very well aware that if you treat STI better and if you diagnose STI earlier and treat them better, so that will reduce the risk of HIV transmission. So that is one of the strategies which can be used for prevention of HIV. HIV vaccines, there are lots of things which are happening in HIV vaccines. There is no vaccine as such as of now, but there are many discussions and many things which are going on, which we will not be discussing in this session, obviously. So one more thing is very important to see here is HIV testing. So HIV testing by itself is one of the most important strategies for prevention of HIV. How it works is, if we can diagnose a patient or a person who is living with HIV early, and if we educate that person and if we counsel that person as per requirement, and if that person is equipped enough with information and knowledge regarding the modes of transmission of HIV, the treatment options available, and all those things which are required for preventing the spread of HIV infection. So that is crucial in this scenario. So diagnosing HIV in early infections and diagnosing HIV in early phase of disease is very important, not only for that person but for general epidemic also. So if we diagnose early, put them on treatment and educate them so that that person will not be a source of HIV infection to the other. Then second group, if we see ARV based strategies. So a couple of strategies what we will be discussing in this session, they are treatment as prevention and also pre-exposure prophylaxis. We very well know about PPTCT program of prevention of mother to child or parent to child transmission of HIV, and it itself is a separate topic, and we very well know that if you give ART to mother, risk of transmission reduces in children. We know now since 2014 it is a part of national program. We are using option B+. Now there are many centers which are coming up with reports, initial reports, that many patients whom they treated with combination 3-drug combination ART, and there are 0 transmissions which are happening to children. So there are many reports which are available these days. And post-exposure prophylaxis I'm not touching on in this session because that is another area again, and many times we have done sessions on that. So we will be focusing on pre-exposure prophylaxis and treatment as prevention. But if you see overall, the thing which is connecting all these prevention strategies, it boils down to HIV testing, early HIV testing, and more good quality HIV testing, and diagnosing people early and putting them on treatment. And these days, if we look around, many guidelines which are available. I'm not talking about NACO guidelines, obviously, but the other guidelines, if you see, even WHO guidelines and all many major international guidelines, if you see, they promote test and treat, testing and diagnosing people early in phase of infection, and also early and then putting them on treatment as soon as possible. So this is one thing which connects these prevention strategies, and overall it reduces the risk of transmission. But one thing again is it should be mentioned here, that no strategy works as a standalone thing. If I talk about treatment as prevention or pre-exposure prophylaxis or any of the other prevention strategies, so it will not affect as or act as a standalone thing. It will be a combination, obviously. So whichever important thing is there, that we will introduce, and then the other prevention strategies will be continued along with the existing strategy which we are going to use. Here is a question before we talk about the treatment as prevention and other things. Approximately how effective is antiretroviral therapy for an HIV infected person at reducing the likelihood of transmission to an HIV uninfected partner? Can you please type your answers in the chat box? The question is, if you are using ART as a HIV prevention strategies, how effective it will be to reduce the transmission from the positive to negative partner. So I'm seeing some answers. I request all of you to type your answers. So there is a lot of D and one E here. So 50, 90. So there are C, D and E. Okay, thank you. So thank you for your responses. So obviously there are no A's and B's here. So there are either C, D and E. So we somehow are sure that there is the ART is actually helping to reduce that transmission risk from a positive partner to negative partner. The correct answer it seems to be E, that is 90% or greater. I'll try to present few data on this just to support my statement that the prevention or the effectiveness of ART as a preventive strategy will work more than 90% of the times. So let's see what is the evidence we have. There is a large trial. Everyone is might have heard about HPTN 052. It is one which we have been listening to a lot of times before. Also, we might have heard about it. Actually, it made a big news in 2011 when it came up with the results of HPTN 052. And based on this, and this is one of the most important trials, which based on which there are many guidelines which were introduced, and it talks about the prevention of HIV transmission also. So there are, and the treatment as prevention actually is based on this trial, and this is one of the most important trials which has led to this prevention strategy of treatment. So you can call it as treatment as prevention, but as this trial will tell us that how important and how good it is, and so that we can call it as treatment is prevention also. So when we look at this map, so in this trial there were almost over 1700 couples were enrolled from all subcontinents, and there are many sites from which the people were enrolled, and all these couples, these are discordant couple. As we all know what discordant couple is, a discordant couple is one partner of the couple will be HIV positive and another partner will be HIV negative. So these all these people were enrolled for this study from various parts of the world. If you see, there is from India also, if I'm not wrong, there are no less than 2 sites. One was definitely Pune, and second was I think Chennai. So there these sites, people were enrolled from these sites for this study. And if you look at this network, out of all these couples which were enrolled for this trial, there were couples who were like here, if you see in this is female and male, female positive, male negative, male partner positive, female partner negative. These are same-sex couples. One partner is positive and one partner is negative. But if you see the number of these clients and couples which were enrolled for this trial, if the representation from the homosexual population was not as large as it actually one could expect. See, in heterosexual male or heterosexual population, the couples from or discordant couple from that group were a large part of this trial, though there were few couple from the homosexual populations, but these were not big enough. I'll come to this part also, why this or how this will be important. Now, as we know that there are various benefits of ART, so once ART was started to the positive partner of this discordant couple, so there were two, the groups were, or the couples were randomized in 2 groups basically. One group received early ART and second group received deferred ART, or ART was started after some time along with this CD4 line. So obviously there were many benefits of ART. So that means health benefits. Obviously, if a person is started on ART, a person's health conditions will improve. Those benefits were there after initiation of ART. But more important than that, in this context which we are talking about, is that once ART was initiated or ART was given to the positive partner, the infection, if you see in the early therapy group, and this is deferred therapy, that is late initiation of antiretroviral therapy, there was only one transmission which happened over a period of time in early therapy group, and in deferred therapy group 27 transmissions they happened. So, and also this one transmission which has happened, it was in early phase of the disease. That person was in early phase of the disease. So there was a 96% reduction in transmission of HIV from a positive partner to the negative partner. So if you look at this result, so it was actually a big news, and all these are linked transmissions. What is linked transmission? It means that this transmission is from that positive partner within the couple itself. So this transmission has not happened from any other source which is outside this couple. So all these are linked transmissions, and if you see, if in the arm of early ART therapy only one transmission it happened, and if in deferred therapy there were 27 transmissions which happened. So this led to the result of 96% reduction in HIV transmission from positive partner to the negative partner in the discordant couples. And actually this, if you see this, and this became one of the most important basis for the idea that the positive partners of the couple should be treated with ART so that transmission risk reduces. Now this happened in 2011, but if you see after 2011, what has happened is all participants were informed of the interim results in May 2011 when this finding it came up. Then ART was offered to all delayed arm participants, because delayed arm participants at that time, they didn't know about the benefits of this strategy. So all delayed arm participants also were given ART. The study it continued until May 2015 to assess the durability of treatment as prevention. If you see this table, and if you see results here, and this is actually talking about the positive transmissions which happened in early arm, and here is delayed arm. If you see the total linked partner infections, there are 46. If I talk about this box on the right side, 46 transmissions they happen overall. That is, this is up till May 2011, and this is after that till completion of the study. So 46 transmissions happen totally in early arm. If you see, there are 3 transmissions which happen, that is early initiation of ART. And if you start ART late, that is delayed initiation, there were 43, and that's how it came to 93% linked risk reduction. So those people who were on ART, in that 3 people in early arm they developed HIV, and 5 people in delayed arm they developed HIV. So in total, in people who were on treatment, these are all the linked infection occurred in someone who is actually taking ART, and these were only 8. So 3 in early arm, like I mentioned, and 5 in delayed arms. And these 8 linked partner infections diagnosed after the index partner started ART, these were further seen, and 4 infections were likely occurred because before or soon after the index partners started ART, and 4 infections occurred after the index partners failed antiretroviral treatment. So we can conclude here that there are 0 transmissions which happen if a positive partner has suppressed viral load. So this was actually a great thing to know that with if a person who is HIV positive in a discordant couple who receives ART and the receives ART within time, and if the viral load suppresses to undetectable level, then risk of transmission it reduces a lot. And as per the study, if we see, there are out of all these patients, only one patient developed HIV infection or transmission happened in one. So we can see that in people in whom the viral load is suppressed completely, the transmission risk is very low, and we can see that 0% transmissions they occurred in this study. Now there is another study we will see, that the partner study. Now in this study, in like previous study when we saw the HPTN 052, it was basically the more people who were enrolled in this study were from the heterosexual group, and like I mentioned before also that the same-sex people were very less in number if you see those study groups. So this partner study is, I'm not sure whether this study has been published, but it has been, the data has been presented in various conferences and meetings. So it actually complements the findings of HPTN 052. Now, why do we want to know this risk is because it affects the way we counsel the patients when we try to talk about the importance of ART when CD4 is high. So as we should be aware that HIV transmission risk will be there in patients, whatever group we are counseling about, we need to have that information with us, which can be shared with the clients. So this is about HIV transmission risk with condomless sex if positive partner is on suppressive ARV. Now here the term which is used is condomless sex and not the protected or unprotected sex, because these days that this specific term is being used rather than using protected or unprotected sexual intercourse, because there are again various meanings of protected and unprotected. So we clearly say these days condomless sex, that is the most common term which is being used. So the absolute risk of HIV transmission with condomless sex and suppressed viral load is unknown, and knowing the risk would help us when to inform the patients while doing the counseling of these patients, especially when someone would like to take suppose decision regarding pre-exposure prophylaxis. And all these informations, whenever you do counseling of clients like this, the information or the data which is available with us, it makes it easier for us to talk about those facts which are sometimes not very clear with our understanding. You require numbers for that. So this is one of the studies which will complement. This is obviously an observational study of serodiscordant couple at various sites of from European countries. So there is every 6 months behavior questionnaire was introduced. HIV RNA positive partner and HIV test was done to see whether partner is negative, and counseling was done, and informed consent for each study contact was done. And the eligible people for this study were those who reported condomless sex, no PEP, no or PrEP, and positive partner viral load is less than 200 copies per ml. Now this again, less than 200 copies per ml is not ideal to call it as suppressed viral load, but in this study this benchmark was used. Now all these people were counseled. It is not that these people were not counseled. All these people were counseled and were offered all risk reduction strategies, and then only they were actually enrolled in this study. If you try to look at the study population, this is baseline characteristics of HIV negative partners of the study population. It talks about the MSM, who makes to 282 couples are MSM here, and heterosexual men where male is negative are 245, heterosexual couples where women are negative, this is 240. Now, and if you see this will tell us about the years of condomless sex, that is 1.5 years for example, and then years in study, that is median, STIs, condomless sex with other partner, condomless sex acts per year, that is on an average it was taken, and then probable number of condomless sex acts. Similarly, HIV positive partners, HIV positive partners, if you see here, so as age and then years are on ART, 5, 7 and 10 years in each group, and self-reporting adherence, and then self-reported viral load. Like I mentioned, it was not ideal, but it was less than 200, which was considered as a benchmark, and CD4 more than 350, and then missed ART more than 4 consecutive days, and then diagnosis of STI, it was in 16%, 4% and 5% of the patients. So here are the results of this study. So all linked transmissions were seen and absolute transmission rate was 0. Then 10 years absolute rate transmission was 0. That means if you start or if you give ART to those people who are positive in a discordant couple, and which has in this study that included heterosexual and both men who have sex with men, the transmission risk was reported to be 0. But if we but this was actually, this doesn't translate to whether there is no risk of transmission from HIV positive partner to negative partner. I think that is difficult to conclude based on this, because if at this juncture these researchers, they also talked about or they also calculated and looked at 95% confidence interval and calculated the upper bound, and what they saw was that we cannot confirm with 95% confidence that upper limit of risk is not as high as these numbers they suggest, simply because the limited number of years of follow-up of these patients. So this will be important in counseling to know that though we say that with treatment as prevention or with starting ART in a positive partner of the couple, we can say that in this study the absolute rate of transmission is 0, but it is not safe to say that there is no risk of transmission. That is actually bottom line of all this discussion. So when you talk to someone where treatment has been started, suppose, and when you and treatment is, patient is on treatment, so based on these results, what you can say or what anyone can conclude is there is a huge reduction in risk of transmission from the positive partner to negative partner, but we can never say that there is no risk of transmission, because for example, suppose if a person gets STI, obviously the chances of transmission will increase. So though these study results, they say that the transmission risk is 0, but there are various, again if you see here, any sex, anal sex, receptive anal sex, all these are estimates based on which this thing cannot be concluded that the risk is absolutely 0. What we can say is the transmission risk is very, very low if a person is on ART and the viral load is undetectable. So this is what their conclusions were: 0 link transmissions over these many years of follow-up. But as I mentioned, there are it cannot completely rule out any risk of transmission. Right. So now second part of this presentation is pre-exposure prophylaxis. So we will try to sum this up in what are the updates in 2016 about pre-exposure prophylaxis. We know many things about the pre-exposure prophylaxis, or we might have heard at least, just to get sense of it. What is the your familiarity with pre-exposure prophylaxis to date? Can you please type your responses in the chat box? Very familiar is A, B is somewhat familiar, C is a little familiar, D is never heard of it. Okay, so we have a mixed group of people. Some are very familiar to pre-exposure prophylaxis. For them, I think this will be a good revision, or they can give their opinion also, because there are some areas which are still gray. And for others, I think it will be a good learning to go through the evidences. Thank you for your responses. So, first of all, what is this pre-exposure prophylaxis and how does it work? As the name suggests, we all know the PEP, that is post-exposure prophylaxis, in which there will be one exposure, and after that exposure we start with drugs. That is, in our program we give tenofovir, and efavirenz, that is combination therapy, and we give it for 28 days, and that is for pre-exposure prophylaxis, post-exposure prophylaxis. For pre-exposure prophylaxis, the patient will be on continued ART for a longer duration of time, and in that duration there can be multiple exposures which can happen. So PEP is for 28 days, and PrEP, that is pre-exposure prophylaxis, the medicines which are given are taken by the client for a longer time, and it should be taken regularly. We'll define what regularly means, how regularly a person should be for a good pre-exposure prophylaxis. Yes, I'll send these slides. So what is it? It is a prevention strategy in which high-risk individuals, they take medication regularly along with continued behavioral risk reduction strategies to prevent HIV infection. Now, in this definition, there are three terms which I've highlighted. One is high risk. That means this pre-exposure prophylaxis is not given to each and every HIV negative person. It is given to people who are at risk or at high risk of acquiring HIV infection. And then the medication, they are given regularly. Again, I'll talk about this regularity of for a good outcome of pre-exposure prophylaxis, but as recommended in international guidelines, it is to be taken daily for a considerable period where the risk is more. So along with the continued behavioral risk reduction strategies, so it is not that we rely only upon one strategy of this PrEP and we don't talk about condoms and other risk reduction strategies. So those obviously will be continued, those efforts are continued, and along with that this will be one additional effort to prevent the HIV transmission. So the risk reduction strategies which will be continued like any other risk reduction strategies which we give to the people who are at high risk. The treatment for that, or the medicine which is used for pre-exposure prophylaxis, is the combination of tenofovir and emtricitabine. In US it is branded as Truvada. So it was approved by FDA in 2012. The added benefits of pre-exposure prophylaxis, though these are not approved by any guidelines, it may provide some protection against Hep B acquisition of Hep B infection, especially if the person is not vaccinated with hepatitis B vaccines. So it provides that additional benefit, and also there will be some protection against HSV, but again this is for a longer duration of time, and though it has been seen that it provides that benefit, but it again is not part of any approved guidelines. So Truvada or tenofovir emtricitabine is the combination drug of drugs which is used for pre-exposure prophylaxis. Now, oral tenofovir based PrEP, what is the rationale? It is again same which we very well are aware, as we are also using combination of tenofovir with other drugs as in our first line also. Tenofovir has several advantages for choice as a first line generation in PrEP. It is a potent broad spectrum drug which is rapidly active, it is safe, and it is well tolerated. Again, low pill burden, it is 1 tablet a day, no food restrictions, and also there are high other virus protections also, which contributes to benefits of this. Now this looks a busy slide, but this is, I think, the most important slide as far as understanding the PrEP is concerned. Now, if we ask ourselves, is PrEP is effective in preventing HIV transmission, we will have to see some evidences whether it is really effective or not. So these are the trials which are actually which we can see here, and this has been included in one slide, though it looks busy, but I'll make it simple for you to just go through it. This is one iPrEx study. It was again it was done in multiple countries, like you see here, Brazil and other countries. So the study population, they enrolled almost 2,500 MSM and transgender women. Then in this study there were again two groups. One group, it received a daily oral tenofovir emtricitabine combination, and other group, it received placebo. And if you see the efficacy of this combination, it reduced the HIV incidence by 44%. So it was very, very efficacious in that sense, if you see the efficacy of this combination. Another study, Partners PrEP study, 4,000 plus heterosexual HIV discordant couples were enrolled for the study in Kenya and Uganda. So daily oral tenofovir, there are three again groups here which were randomized: daily oral tenofovir, then tenofovir emtricitabine combination, and placebo. So three groups, people received the drugs, and if you see the efficacy here, it is again very high, 67% and 75%. One more study, TDF-2 study in Botswana. Over 1,000 heterosexual men and women were enrolled. Again, in two arms, patients were randomized: daily oral tenofovir and emtricitabine and placebo. And if you see the effect of tenofovir emtricitabine combination, it is 63% reduction in HIV incidence. Then we come to two studies here, PrEP in Kenya, South Africa, Tanzania, and VOICE. These studies were done in women, and if you see the results here, unlike other three studies which we saw, these were very discouraging. There is no protection at all. There is no protection with any of the drugs they used: tenofovir emtricitabine combination, and tenofovir gel. Now this was discussed a lot. Why this happened? Because other studies, they showed very much benefits of PrEP or efficacy of PrEP, but these two studies, they didn't show any benefit. The main reason which was found out for this was poor adherence, and in these women, and the further down the line, they tried to understand what was the reason for poor adherence for the PrEP, and one of the most important reason which came out was high stigma level. So because it is not easy for a negative person to keep ART medicines, especially if the HIV prevalence is high in that area, and people know about HIV, and you are keeping, suppose, HIV ART medicines and taking them. So obviously it might lead to stigma, and this is what happened in this population. So in these two studies, there was no protection reported because of PrEP, and it was understood and it was reported that all this was because of poor adherence, and one of the factors for this poor adherence was high level of stigma in that society. Then another study, Bangkok tenofovir TDF study, again close to 2,500 patients were of injecting drug users were enrolled, randomized to daily oral tenofovir or placebo. Again, there is a 49% reduction in risk of transmission. Then Then iPrEx, so this is one again French study where 400 MSM were enrolled, again randomized to on-demand tenofovir emtricitabine combination or placebo. Now what it means on-demand is whenever it was not again a regular prescription of the PrEP in these patients, or in these groups they were provided PrEP only when it is demanded by those groups. And prevention, if you see the efficacy of the PrEP, it was 86%. Then there is another study which is called as PROUD study, which was done in UK, where 545 MSM and transgender women were enrolled. Now, unlike all the other studies which we saw, which were done in a setting of clinical trials, PROUD study was done in setting of clinical practice, which is directly in the field, where people were randomized to daily oral tenofovir FTC immediately or delayed. So immediately it was started and it was delayed in some way. So when you give PrEP when it is required immediately, then there is the efficacy of that was 86%, which is again very high. So if you try to summarize in this graph, if you see, it summarizes overall efficacy of PrEP from all those trials. So tenofovir emtricitabine as sexual PrEP for HIV prevention estimated protection from the transmission. So estimated protection from PrEP in all participants, if you see, these are the results. If you see here, this is about the partner study or serodiscordant couple, TDF2 study, again 63% iPrEx 44, and these two studies in women where we we talked about this, that as HIV the drug adherence was low, the PrEP was not useful at all. How about using lamivudine instead of emtricitabine? There is no recommendations on that, because the drug which is approved for PrEP as of now, this is tenofovir emtricitabine. There are no studies which are available which have used lamivudine in place of emtricitabine for PrEP. From when the PrEP would be available at ART center? No. So at present it is not available. It is not, and that's what actually I tried to make it very clear in the beginning of the session, that whatever we are discussing here as of now, this is not part of a NACO guidelines. We are talking about the evidence which is there, and we should be aware of what is happening in the field. So as far as ART center is concerned and implementation of all these strategies is concerned, until anything comes from NACO as such as a recommendation or guideline, then only we are going to use it. I think I'm very clear on that. Now, estimated protection in all participants of all these studies and versus adherent participant, those participants who are adherent to the PrEP medications, and this shows that in all these three studies adherence was good. And there is, when it is said that what is the efficacy of PrEP, so overall efficacy, it is said to be 78 to 90%, if not 100%. But what is one thing which is very clear from all this information is the most important thing will be adherence here. That adherence should be really good for an effective pre-exposure prophylaxis. So it cannot be 100%, because again, if suppose a person is person's virus is resistant to tenofovir and emtricitabine, obviously there will be a failure of PrEP. So that is why maximum protection what we have seen is 90% and not the 100%. So this should be part of the counseling when we talk about PrEP to any, or if anyone talks about PrEP to any client. We cannot say that PrEP will be 100% protective. The protection which is shown along with the usage of other prevention strategies of risk reduction, it is 70 to 90%. Now this is adherence and efficacy in iPrEx, that is iPrEx Ole it is called. It is again an extension of iPrEx, open label extension, and it is to see is PrEP needed daily, or is PrEP is to be given daily, or is the drug is to be given daily to have this protection, or a patient can miss some of the doses. So in this extension study, about every person was offered, or all these people, all from iPrEx study were offered PrEP, both placebo and the people who received medicines, and 76% of them they chose to receive PrEP. And adherence was measured by random blood sampling. Good processes, actually adherence was done with good TDF, by measuring the TDF in red blood spots. So that is again a good method of checking the adherence in these patients. So the HIV incidence was seen along with the number of tablets which are used as PrEP. If not taken, what is the HIV incidence? If less than 2 tablets per week are taken, then what? And then 2 to 3 tablets per week, 4 to 7 tablets per week. So here there was no transmission which happened if a person takes daily PrEP and maybe 4 to 7 tablets per week. This also leads to a question of whether a person who is taking less than 7 tablets a week, or maybe 4 tablets a week, will that be enough for zero transmissions to happen? So this again further is difficult to comment on this, but at this stage what we can say that and this is again option which is for us to think, and no one has a clear answer for this. But as far as guidelines are concerned, guidelines, I'm not talking again of NACO guidelines, the international guidelines, for example CDC guidelines, they say that it is to be taken every day and people should not be missing the doses. So 4 to 7 tablets per week will help to have no infections or no transmission of the infection. So from a provider perspective, it is important to emphasize on daily treatment, and though we can be satisfied if a patient or a client misses 1 or 2 doses. Can we recommend PrEP for a negative partner in serodiscordant couple? As of now, no, because there is no any recommendation from NACO as such as a guideline. So if it comes as a guideline tomorrow, that is different story. But once if that has not come yet to the ART center, we are not giving even the ART to the positive couple of the serodiscordant couple unless that person is eligible for ART. We are not giving, and PrEP there is no question unless it comes as a strategy of prevention in our country. So there are certain concerns regarding PrEP. Is it safe? So we need to see whether PrEP is safe or not. What about toxicities of the drug which we are using? Will it lead to resistance to HIV? In future, if suppose this person gets HIV infection, whether tenofovir will be we will be able to use tenofovir in that patient or not. Then if suppose we are starting a drug in a person who is HIV negative, will it lead to increased high risk behavior of that particular patient? So first we'll talk about the is it safe. So about safety of the drug which we are using, for example tenofovir and emtricitabine which we are using for PrEP, there can be some initial side effects to the patient like nausea and headache and fatigue, but usually these last for 2 to 4 weeks. You all might have seen that because we already used tenofovir, but these are generally they generally get resolved. But as far as the other side effects are concerned, like renal toxicity and bone marrow effects, so for this the regular monitoring of the patient is required at least once in 3 and 6 months. So in clinical trials, changes in renal function not more frequent with tenofovir than placebo, though follow-up is limited. Monitoring of every 6 months is recommended. Similarly, bone side effects are there with tenofovir, which are very well again reported. Again, no increase in fractures were seen in this clinical trial patients. So, see, if you use any treatment for a longer duration of time, then there will be a risk of again more toxicities or accumulated toxicities, though it may not. So bone marrow again toxicity is one of those. So PrEP should not be seen as a lifelong intervention for prevention of HIV, but it should be used as a focused intervention where the risk is high. To reduce the risk, we can use, and then it can be stopped after that risk is reduced. In that period, risk reduction strategies need to be strengthened. Now, the second concern we talked about was whether it will lead to drug resistance. Now, this is again a table. So, in the clinical trials, those who were infected after enrollment, they did not develop resistance with the exception of acute HIV that was missed at the entry into the study. So people in window period, again they if suppose, and what it means is, if suppose we diagnose HIV, if we miss HIV diagnosis in a patient, and if you start PrEP in those patients, obviously the HIV will survive, and if HIV survives, if the person becomes infected with HIV, in those patients, as we are using two drug combinations here, you can see here the mutations which are, have appeared. So these acute HIV infection at enrollment, if you give PrEP in those patients, they had the resistance, and we know that K65R is with tenofovir and M184V and FTC is with FTC or emtricitabine. Then HIV infected, and if suppose you are giving PrEP to some a client for HIV prevention, and further down the line, if suppose patient becomes HIV infected after enrollment, there was no transmission which was or no resistance was seen in those patients, and PrEP was and tenofovir was again effective in those patients. So the risk of development of resistance is low. And but again, it is very necessary that HIV infection is ruled out at the beginning of starting of PrEP. Now, this is one big challenge, that to rule out HIV infection, if a person is in window period, suppose, then again it is furthermore difficult to rule out HIV infection with existing mechanisms of HIV diagnosis here. For a person, suppose for example, if someone is very much motivated to get the PrEP started, if that is the case with us, and he or she says that I had condomless sex with high risk person just 4-5 days ago, whether I should be receiving PrEP or not. Now, in this scenario, where we are not sure about HIV diagnosis, again both antigen antibody testing need to be done, and to make sure again further PCR or RNA PCR or viral load need to be done in such patients to be absolutely sure that these patients do not have acute HIV infection or any kind of infection in the window period. So it is very important to take that decision. Unless we rule out HIV sufficiently, we cannot jump on PrEP at this stage, and that might be the reason. It again is a big question to be discussed at length in various settings, whether this is possible to be implemented as a part of national strategy or any prevention strategy for that matter. But you cannot wait for a long time for this to come, because it is again being discussed at various fora, like I mentioned. So at some point of time, that decision will have to be taken, whether we are missing on this part, and whether we should go ahead and start PrEP again. But this is a big question to be answered. There is a question: if a patient is a PLHA and his wife is negative, if they do condomless sex and wife exposes with semen. This case is recommended to give PEP, not PrEP, to the negative partner. I would say yes in principle, but if you talk about the guidelines in NACO guidelines, there is no provision as such as of now. But you're right in that if a person is HIV positive, wife is HIV negative, they do condomless sex, and here there is no question of PrEP because exposure has already happened, so the person might need PrEP. Again, we are not talking about guidelines here. Then the third concern which we talked about was what about the sexual risk taking, whether people who use PrEP, their behavior will become more risky or what. But this again study was when people were not aware of beneficial effects of PrEP. In that, and where in the study people were given PrEP and placebo both, and there it was seen in iPrEx, for example, the risk actually the risk taking behavior, it declined, maybe because people became more aware of the transmission risks and they tried to have safe sex and other risk reduction strategies, and also partners study, the same findings was seen. But when people became aware of benefits of PrEP, there are, again, this is one demonstration project which talk about whether risk taking behavior is reduced or not. So 657 PrEP initiators from 2012 to 2015, 99% were MSM, and after 6 months and results were seen, then the risk reduction was, again, the risk taking was unchanged in 74% of the people, that is again a major chunk. Condom use was unchanged in major group, like 56%, and decreased in some, or almost 41%. 50% were diagnosed with at least one STI by 12 months. That is, by 1 year, 50% were diagnosed with at least one STI, but not HIV. Again, there is zero diagnosis during 388 years of follow-up. So HIV was not diagnosed. That in conclusion, what we can say from this is, if we ask whether it will lead to more high-risk behavior by the patient, then the answer is no, or what we can say safely is the risk-taking behavior is unchanged after PrEP. From the other side, forget about the concerns. If we look at the other sides, how patients they feel or about the PrEP, they feel more secure with PrEP. Especially in context of peace of mind, if you look at it from that perspective, it will reduce their anxiety, increase the communication, and increase the intimacy and self-efficacy, and increase sexual pleasure with the partners. Then who should get PrEP? I'll wrap up within 5 minutes or so from here. So these are the guidelines, these are official guidelines from CDC for 2014 for PrEP in MSM, heterosexuals and IDUs. I'm again repeating that PrEP is not a part of prevention strategy in NACO program. So this is for the information that how this is used and what are the various guidelines around the globe. So we will talk about few things which are mentioned in CDC guidelines about PrEP, and then we'll stop. Who should be considered for PrEP? Any individual with substantial risk of HIV, for example, a man or woman in relationship with a HIV positive partner, that is a partner of a negative partner of the discordant couple, then gay or bisexual man not in a mutually monogamous relationship and not using condom 100%, man or woman with recent STIs, then or with sexually active with high risk individuals, man or woman who uses injection drugs, commercial sex workers or female or male sex workers, and serodiscordant couple who want to conceive. Now this is one question which regularly comes up even in our practice at ART center when people come to us, whether and like serodiscordant couple, where especially when male is positive and female is negative, and if they want to have a child, what options do they have? And we usually talk about the sperm washing and IVF and IUI. Sometimes it is expensive, but IUI is something which can be advised, that is intrauterine insemination after sperm washing, which is not very expensive. So these are kind of people which are actually very much suitable for PrEP when they are serodiscordant and positive partner is on ART and viral load is suppressed, and you advise PrEP to the negative partner, and then after that if we do the sperm washing and all, then it is again risk we are reducing a lot more than the existing one. How long do we have to take PrEP? There is no, like I mentioned before, you need to see the risk of exposure. If suppose a person is very regularly using condoms without missing a single time, then I don't know what additional benefit PrEP will give to those patients, those people, in terms of reducing the risk. So PrEP might not provide any additional benefit if a person is already using. So it all depends on the other prevention strategies, if a person is regular in doing that or not, and if a person is doing that, then it might. But when there is risk in that period, in that duration, PrEP should be regularly taken, and then also the efforts should be made to work on the reduction of high risk behaviors. And baseline evaluation for prescribing PrEP, we see the ongoing risk and whether patient will be able to, or client will be able to take a pill every day and return after 3 months for testing, screen for HIV and consider need of RNA. Sorry, Hep B need to be ruled out, renal function need to be seen. For PrEP, absolutely we need to have very good renal function or absolutely normal renal function. Then how it is prescribed, 1 tablet a day, not more than 3 months at a time, and because we need close follow-up, emphasize on importance of adherence. Continuous counseling is required for other prevention strategies, and please remember that this is not a standalone strategy. Then in lab monitoring, every 3 months HIV tests need to be done, which might include viral load also, like RNA testing. Then every 3 to 6 months STI screening need to be done, renal functions at 3 months, then every 3 to 6 months. This is all as per CDC guidelines. Then so what can be the summary of eligibility criteria? We already saw that the substantial risk need to be considered, documented negative HIV test before prescribing PrEP, no symptom of acute HIV infection. People who are taking PrEP need to be taught about the symptoms of acute HIV infection. That is very important. The absolutely normal renal function, documented Hep B status, able to adhere to daily medications, and ready to come for frequent visits. And these are the lab parameters which need to be seen at baseline. All HIV assays, antibody, HBV and HCV antibody testing need to be done. Serum creatinine, STI and pregnancy test. And every 3 months at least HIV test and higher HIV test like antigen antibody or 4th generation ELISA and the RNA testing. Pregnancy tests need to be repeated every 3 months. At least at 6 months serum creat need to be repeated, and STI counseling need to be done. And when we say that normal renal function, that means creatinine clearance should be less than 60, which is a normal thing. So at a minimum, document a negative test result within 1 week before initiating on the PrEP. It can be a serum lab-based testing or point-of-care testing. What is not advised is we don't use those tests. So if negative or indeterminate screening of the result in a patient with recent signs and symptoms of HIV, repeat screening in 1 month and send HIV RNA PCR, which means viral load need to be done. And about the counseling, regular follow-up counseling is done, behavioral risk reduction, side effect, STI, women, about the pregnancy and contraception, then cleanliness, and then about the refill of the drug. So this is the last slide. There are again many things which again can be discussed under each under each of these questions, which are not yet answered, but there are many things which are being done to try to answer these questions. So what is the role of intermittent dosing, whether intermittent dosing can be used or not? We saw one thing, that at least if a person takes 4 tablets in a week, that may be sufficient, but we do not give that option to the patient. We say that take 1 tablet every day, or as recommended by CDC guidelines. How soon after a person starts PrEP is it protective? So this is again, like I said, from before starting the exposure, that long duration of the treatment, there can be exposures from at multiple points. So the treatment will be started well before the exposure happens. Now, but again, to answer this question, there are no clear answers at definitely what time before we can start PrEP. How effective are the other drug besides tenofovir-emtricitabine? There are certain drugs which are being studied, but again, nothing is recommended as such as a replacement of tenofovir and emtricitabine. What is the optimal way to transition from PEP to PrEP? If again, that if a person is exposed, then if you are giving post-exposure prophylaxis, and then when it need to be transferred to the PrEP, that is again one question which needs answer. What are the benefits for an individual whose partner has HIV with suppressed viral load? Again, we saw there are many benefits of PrEP if the partner has suppressed viral load, but what additional benefit it will provide, again, it has to be supported by evidences that what exact benefit it will provide. Like I mentioned, that there may not be any additional benefit if people are using regular prevention strategies, and if we consider ART treatment as one of the good treatment strategy, then that again is one question which need to be answered. So this is what I think. These are the 2 topics which I selected very carefully, not to confuse anyone on this. I don't want to confuse anyone that this is it is not a NACO guideline as such as of now, and whenever guidelines they come in future, then we can talk about the implementation part. But what we tried to discuss in this 1 hour was what actually PrEP and treatment as prevention stand for, what are the benefits and what is the evidence behind using this strategy for prevention of HIV transmission from one person to another. So I think this was helpful, and thank you very much for your participation, again for your questions and discussions, and special thanks to Dr. Rajshekharan again. So I'll circulate the recorded link along with this presentation also, and I'll be happy to answer questions if they come in future. So this was actually one of the topics of the course which we did recently with the ART medical officer from the University of Washington. So I acknowledge the clinical management of HIV course for this presentation. So thanks again, and look forward